Hello, my name is Michael Hager. I'm the Manager of Technical Assistance and Dissemination at the National Quality Center and the Manager of the end+disparities Learning Exchange. I'm really excited to welcome you to one of our final webinars for the Learning Exchange entitled Greater Than the Sum of Its Parts. And we have a number of community presenters on the line today to share a little bit about what they've been doing in their setting around disparities in HIV care outcomes. And we're hoping to really engage all of you in a discussion around what you've tried, what you've thought of trying, and just ways that we can spread around the learning that we've had at our own sites across the Ryan White HIV/AIDS program community. So before we start, one of the things that we like to do is just to kind of get a sense who's in the room, just to put your name and your organization, a little bit about yourself in the chat room. This information we then use for our chat transcript, and it's just good to see who's been participating. So I'll start, Michael Hager, NQC, New York, and disparities leader. And just one thing, when you enter information in the chat room, try to make sure that the send to is set to everybody so that we're able to all see each other's questions and comments. Otherwise, they'll just come to me. So just a couple of ground rules. We really are excited to have everyone on the line to share what they've been doing, what they've been thinking around disparities as we wrap up the end+disparities Learning Exchange. We're hopeful that you'll use the chat room as an opportunity to kind of sound ideas off of each other and to have some reactions to the presentations as they're being made. You can also put your questions there. We're going to start out by having all the lines open, but of course, if people are putting us on hold and we have the on hold music or other distractions, I'm going to go ahead and mute all lines. If you do need to mute your line, you can press *6 to mute your line and *6 to unmute your line. If you're also tuned into the webinar itself, you can find your name in the participants list and click the little orange or gray button to the right of your name. You can click it again then to unmute your line. One of the things that's important for this initiative, it is a bigger, more intensive initiative. So we have a bigger, more intensive evaluation. And there will be a survey that we send out in addition to the recording and the slides after today's webinar. Okay. And for those of you who are less familiar with Learning Exchange and might be joining us just for the first time at the tail end, it's a 9-month initiative to promote application of improvement interventions that reduce HIV disparities in 4 populations while building and sustaining a community of learners. Of course, we've talked about different populations and groups beyond our 4 subpopulations as a way to think about intersectionality and the way that concepts related to disparities in care can actually be found across populations and not just within a single population as well. We offered a number of different webinars, including webinars like today. We have webinars that are geared toward consumers called Partners in Care, and then also informal discussions where we, kind of kick around a theoretical can called Office Hours. The recordings to all of the webinars you can find on our website, end+disparitiesexchange.org, and by clicking Review on the home page. For those of you who are less familiar with the National Quality Center, this is, of course, just one of the many things that we do. We are actually transitioning our funding on June 30th into a new cooperative agreement with our federal partners. So some of this is bound to change, and we're excited to continue thinking about our forward motion past July 1 as we get to that point with our federal partners. But for now, if you go to nationalqualitycenter.org, you can access all of our historic publications, activities, and slide sets and recordings. It's a wealth of information with thousands of resources related to quality improvement and clinical quality management as it applies to the Ryan White HIV/AIDS program. So I'd like to turn it over to one of my friends and colleagues, Judy Popkin. Judy is one of our NQC coaches who's based in Florida, and she works with Floridians and Georgians on their clinical quality management programs related to Ryan White. Judy has years of experience doing clinical quality management across an array of clinical issues, including HIV, and we're really excited to be partnering with her as a facilitator on today's call to help us think think through what is spread and to kind of get at some of the core of what's been happening in the Ryan-White HIV/AIDS program community through this initiative. Judy?
Hi, Michael, and good afternoon, everybody. Thanks for joining us. Our webinar today is focused on making sure that the learning we have in the field is spread around the Ryan-White provider and consumer communities. After that, we'll open up the webinar for your questions in our Q&A session. We have some learning objectives that we've outlined for today, and primarily they're to explain what spread is and its importance in QI work, to list 3 things that Ryan-White providers have done around the country to achieve health equity, and to explain 1 to 2 next steps your agency can take to continue advancing quality around health equity. So,
what is spread? And I'm wondering if I could take the time just to see if anyone on the line wants to share what their understanding of spread is before we get started. Just a reminder that if you are muted and don't hear us reacting to you, you can press *6 to unmute your line. Does anyone want to get started and kind of share what they feel spread means and what spread is?
Well, if we don't have any volunteers, I can give you a little bit of a brief overview. This is Judy. Spread is making sure that the work we do is communicated within our broader community so that other people can learn from it too. For example, it's easy to close shop and move on to something else when we finish one QI project, but it's best to complete a write-up or produce some other accessible media around what you did, how you did it, and what you learned. You can save it online, put it in a newsletter, share it on a bulletin board, speak on it at a conference in an abstract, or a piece of the literature. But the important thing is to make sure that the work just doesn't get put away in a drawer somewhere, but that you share what you've learned and what your continuing challenges may be so that more people benefit from your work.
Absolutely. For all intents and purposes, we're talking about the concept of dissemination. And in clinical quality management, we use the term spread to represent that. So I think one of the things to keep all of the topics that we've been putting on the table together is just to think back to our discussion in May. And if you didn't participate in that one, listen to those recordings later on. We talked a lot about the importance of having a written sustainability plan that you can generate as part of project planning and strategic thinking exercises. When you're thinking about your project at the very beginning, thinking about how you can sustain that work moving forward and thinking how you can disseminate it when you're done is really important for that, front-loading the work in terms of planning in your Plan, Do, Study, Act. Judy, I don't know if there's other thoughts you want to add.
Well, I think this is really important. You hit it on the head. You think of the opportunities you'll have to spread your work and think strategically about how, when, and why you share certain details in certain ways. For example, you could produce an infographic to share with consumers so they can take it to other places they receive their care for discussion. You could write a scholarly article or an abstract to share through academic channels and journals and at conferences at various levels. You can create a new training module that all new staff and perhaps new cross-agency regional group members can use to come up with or new best practices. I was just wondering if anybody has an example of a project that they spread and how they went about doing that.
Whether it's related to disparities or something else, does anyone have a specific dissemination plan or anything that they've done around spread that they'd like to share? Shy group, I don't know if it's the heat kind of melting us down here, but one of the things that we hope to do today is to model, of course, what we're talking about here. And in thinking about, you know, sustainability and dissemination, we put together this calendar of webinars going way back, you know, August of last year. So did we know what we were going to be spreading when it came to June, 11 months later? We most certainly did not. I mean, in fact, that is something that we'd want to avoid. We want to avoid that inductive logic, and instead we want to deduce what is good and what is worthwhile to spread. So we just kind of held this in our hat and said, this is going to be the time that we do this. We had faith in all of you in the community that you would be working on this throughout, and that there would be some solid themes and trends that we could kind of pull together to think about in a meeting like this. So what we're going to do in the next several slides, and probably over about the next hour, is to have a discussion with three folks in particular who used the end disparities tools, identified a number of populations, but one thing in common is that they all initially thought that they were working on youth, and then you'll see that depending on whether they are part of a network or whether they're an individual provider, the nuance around what they did in terms of trying to analyze and to dig really deep and to dive deep into their data around what are the root causes for this disparity, then played importantly in the way that they designed their interventions that will affect them. So we're really excited to welcome our three presenters to help us think about this issue in a concrete way that's consistent, and then hopefully to engage all of you in a discussion, as part of this presentation. And one thing I just want you to keep in mind is, even though a lot of these, presentations we're going to hear are pretty focused on youth, the concept is spread. So of course, we should react to the work that is being described with regard to youth, but we also want you to think critically about the work that you're doing and how you can, make sure that that work gets out into the community and that the lessons learned that you have are taken on, appreciated, and valued by others and aren't just sitting on a shelf somewhere to grow stale and collect dust. So,
yeah, and what we're doing today is a perfect example of spread, just by virtue of having our presentations and having everyone that's present on the webcast and those that will listen subsequently is a means of spread. So I'd like to take this opportunity to welcome and introduce Lara Jackson, who's a Quality Improvement Specialist in Tacoma, Washington. She's the Community Quality Improvement Specialist at Community Healthcare in Tacoma. She has years of experience in clinical quality management across a number of settings. Today she's sharing the work at her agency, which is focused on reducing disparities in HIV care. Lara, thank you for being here, and I'll let it turn over to you.
Thank you. Everyone can hear me, right?
Yes, ma'am.
Mm-hmm.
Yes. Okay. So I'm Lara. I'm the Ryan White Quality Improvement Specialist here at Community Healthcare. And just for some background, Community Healthcare is an FQHC that serves Pierce County and Washington State. And at our clinic in the city of Tacoma, we have a Ryan White program that receives Part C and D funds, and we serve about 400 people annually. We're really it's a clinical basis, so we have a small clinical team and then some part-time small support staff kind of supporting that. So I was new last year, and this initiative came along kind of at an opportune time for me to use it to start to better understand the data for our HIV population and share it with the QI team here. So one of the first things we did was, as a Ryan White team, we watched the End Disparities YouTube video together at a meeting, and then we sat down and plugged some of the data that I had into the calculator. And initially at that meeting, we identified disparities for our youth, our trans patients, and actually our Latino MSM. So we started to have a conversation about what barriers might be, what sorts of things were affecting those communities in particular. But we felt pretty quickly that the conversation was just too general and kind of assuming, and so the team sent me back to do chart reviews. And since we have a small population, I was able to go through the medical charts for each of the people who are not virally suppressed and kind of pull out themes. And across those demographics, themes jumped out at me, not surprisingly, were histories of trauma, instability in housing, and mental health issues and active substance use disorder. So I then wanted to see if I could use the calculator to verify that, that we did have disparities along these parameters. So I entered back into the calculator our viral suppression numbers for our unstably housed patients, temporarily housed patients, and then kind of as proxies for mental health and substance use disorder, I used the most recent scores that people had on, say, their PHQ-9 for depression, or we used something called the DAS that we do during clinical visits to look for issues around active substance use disorder. So when I did that, I saw that, yes, I did see very large disparities between people who we had some sort of data evidence that they were experiencing these issues in comparison to people who were not. And so then my curiosity led me to just look at all the viral suppression for kind of all the data I had, and I made this kind of spectrum. I don't know if you can see it, but it's kind of a spectrum of everything I could think of, so I could see that we were really identifying what our low end was with viral suppression. And I brought that back to the team, and it was really interesting to look at. You know, we have populations that are 100% virally suppressed, and then all the way down to like 60%. And so on our low end, it was those categories. So unstable housing, issues with depression and active substance use disorder, our youth, our trans patients. And so in talking about it, we didn't think that there was an immediate PDSA that we could just do and solve those issues, and we were also in the middle of several other big projects. But what we have done is, one is that we started to focus our capacity building in those areas. So this is showing us what our weaknesses as a program. So the first thing was understanding, okay, these are the people that we're not serving as well as we should be. So in terms of capacity building, we had trauma-informed care training. We've been watching and sharing and talking about some of the webinars in the end+disparities initiative to kind of better understand some issues facing youth and trans patients. And then really it's been about thinking about how we can shift our model to better address some of these more high-needs patients. So recognizing that we need to build up our support services and our capacity to deal with these specific issues. So looking at models for better integrating mental health and chemical dependency services into kind of our clinical care. And looking at how we budget, how we staff, you know, as funding applications come up, kind of directing them towards with these priorities in mind. And so now, you know, it's been a couple months and we're starting to enter, we set our goals from July to June. So this year as we're setting our goals, a lot of them have to do with addressing these specific disparities and maybe doing some PDS projects this year that specifically address these groups. And another important aspect has just been sharing with our stakeholders, you know, from all levels of what we're seeing and how we're responding to it, and asking for input and advice and resources. And so that includes our client advisory group, the larger FQHC QI group and leadership. We have a state QI group, and then also our partner agencies within the community. So I don't have any, you know, well, we, you know, raised this by this percentage and we solved all these problems, but it really has helped us, you know, hone in on our program weaknesses and try to reprioritize where we're shifting our energies. And that's all I have.
Beautiful. Well, I don't know if anyone has any questions. Oh, I see a question from Christine. Is there any particular age group that you're working with in your clinic? I know that you said Part C and Part D, but in terms of identifying disparities, were there particular ages that were more at risk?
Yeah, so we serve from age, I think our youngest patient is 10 and our oldest patient is, 75 or something like that. But when I did that sort of ranking of viral suppression, it was like our youth under 24 are by far our lowest, and then maybe 5 percentage points higher is 25 to 35, 5 percentage points higher is 35 to 45. And then our 65 plus are almost 100% virally suppressed. So it was really interesting to see that viral suppression increased that evenly as ages increase. But what we're really looking at, and it's we have maybe about 15 people who are under 25, but we see much lower rates of viral suppression among them, and it's a mixture of our perinatally infected and otherwise infected.
Great question. Thanks for that. Laura, one of the things I really like about your presentation and also your matter-of-factness around the way that things pile up and interact. Just because someone said there's an end+disparities learning exchange initiative doesn't mean that there's a magic wand that wraps up all the other work that you're working on so you can focus on this new, exciting, important thing. And I really appreciate and value your forthrightness in saying, yeah, we have priorities that we're working on now. We're very interested in disparities. And there's a way that you can practically and just very practically wrap up existing programs while starting to do the strategic thinking around the next project, which is what's going to end up kicking off, I think you said, in July, September. Let me just mute that line. There we go. So I really appreciated that, and I'm wondering if there's anything that you can share a little bit about kind of, I heard root cause analysis, I heard SWOT analysis, I also heard a little bit about kind of like thinking about how the pattern of care, staffing, and training affects patients, and to what extent is this actually you're thinking about what the interventions will be, and versus doing the interventions now? And have you guys started to think about what metrics you might have in place when you are starting to measure this stuff?
Yeah, one thing I've been looking at a lot is these models, the spurt of the screening, brief intervention, referral, and treatment that they have for integrating substance use treatment and mental health into primary care. And so we recognize that we have our HIV specialist and nurse and care coordinator who are doing some of the screening, and then we have a therapist and a nurse psych NP who are doing kind of the treatment, but we don't have the brief intervention in the middle of it, and our clinician doesn't, and our nurse and everyone, it's like one person in each of those roles for 400 clients. And so we end up that in that moment, like if someone comes in and they want to get into treatment, kind of the whole team goes to that, and it takes up the whole day. And so we need someone on staff really in a social work position to help with those brief interventions or reacting in those moments and kind of following through. So what happened was I was looking at those models and bringing them to the team and talking about it and really figuring out, this is, from what people were telling me what their day was like this is what we need. We need someone to fill in this particular gap. And so I'm also looking at then, when we are able to fill that particular gap, how are we tracking the screening to, all stages of that? Who goes from screening? Did they get a brief intervention? Who got the referral? Did they follow up with treatment? And then are we seeing progression with that? So I think about setting metrics along that. How are we responding to when we're identifying these issues? How are people moving through that process?
Beautiful. Well, thank you very much. I don't know if anyone else has any questions specific to Laura before we move on to the next presentation.
This is Judy. I just wanted to say that I think it's wonderful how the calculator was used in, I don't want to say a non-traditional method, but the fact that you were able to drill down even further once you found some disparities. And I wanted to know if it was an easy process for you. You're not a statistics guru, or was there a way that you could easily explain it to the consumer group as well?
Yeah. So with the consumer, with the client advisory group, so we had, this is, you know, one of these typical situations where I came in, the group had kind of fallen off, kind of starting it again and going through some training. One of the challenges I find, and I found this in doing community education too, is it's not so much of saying that there are disparities, but framing it in a way that that people without a public health background don't think don't react to it as if it's blaming that particular population, right. Or like one thing that came up was in talking to consumers about youth viral suppression, and the consumer group that we were having that conversation with, sometimes we have 1 or 2 youth come, but we don't really have as much participation from youth in our client advisory group. And so when the youth disparities came up, there was a little bit of a negative reaction of like, oh, you know, like youth these days and they don't take care of themselves and this and that and the other thing, and that led to another discussion. And I've had that come up in the past when there's been, you know, community education or discussion around disparities with people of color that, like both ends of whose fault is it that there are these disparities? Why do these disparities exist? Which is hard for everyone, but also kind of an emotional reaction as if it's putting something on a particular group. So I don't find that it's the calculator that's an issue, but sometimes having, you know, it's really easy to talk to the state QI group or the rest of the team about these things, but disparities can kind of be a controversial issue if you don't frame it right and take the time to be careful. And I don't know if that's something that's come up in other discussions, but that's something that I've experienced.
I think your point is well taken, and appreciate that insight. Really, really interesting.
A question came in from Alicia. She said that she'd like to know how you went about developing the plan of action for your research focus. And she'd like to do something similar, but she isn't sure where to start with creating an outline for the project at her own site.
I wish that I had a plan or an outline, but I kind of just went with what I was curious about and interested about at the time. I kind of just, you know, wanted to see where it led me. But one thing that I thought was important was going back and doing those individual chart reviews. Because, for example, when we started to have a conversation about our Latino MSM, the things that started to come up were like, oh, do we have some language barriers? Is this something, you know, we do have, you know, gay Latino immigrants that we serve who have, you know, issues with documentation status, and maybe that affects their, you know, their work flexibility. So we started to have kind of conversations about that where we latched onto the Latino thing. And then when I went back and I looked in the charts, all of our Latino MSM who were not virally suppressed were U.S. born, English speaking, but it was meth use. There was a lot of meth use. So that was really like, oh, you know, the things that occur to you first from literature or maybe from other situations. You know, I worked in the South before, and we had you know, a different population. Those are the things that popped up to me immediately, but it was really actually going and looking at our patients, these specific individuals, and not making assumptions. So I didn't have a plan. I just kind of had an open mind, and so did my team, and we just kind of saw where it led us, basically.
Cool. Thanks for that. Yeah, it sounds really organic, and that's one of the things I really like about, you know, the work that you do, that it started with a conversation, and then you just kind of kept going down the rabbit hole, like conversationally and as a team. Like, sounds really cool. Okay. So if there aren't any other questions,
I'll take this opportunity then to introduce Caitlin Thomas, who will talk about her work on Long Island. Caitlin is the SPARK project coordinator at Stony Brook University on Long Island. She's heavily involved with their Part D funded program and leads the development and implementation of evidence-based strategies to improve patient performance along the HIV care continuum. She's a big believer in meaningful consumer involvement and has a very impressive story to tell in terms of her work on Long Island. Welcome, Caitlin.
Thanks, Judy. If I keep this on speakerphone, can you hear me?
Yes, ma'am.
Okay. I'm Caitlin Thomas. I'm the project coordinator for the Rhine-White Part D program at Stony Brook in Suffolk County, New York. And Suffolk County makes up the eastern two-thirds of Long Island. We're a suburb of New York City. And while Stony Brook is actually less than 60 miles from New York City, we measure distance here in the more meaningful language of time. So it's 2 hours by car without traffic. Our county has a population of about 1.5 million, and Stony Brook University's Medical Center provides primary and specialty HIV care throughout its system, but for the purposes of looking at patient retention, viral load suppression, and health disparities, we really focus on the work of our adult, pediatric, adolescent, and family medicine HIV clinics, which serve a combined total of a little over 750 HIV-positive patients. So Stony Brook has an HIV Consumer Advisory Board, or CAB, that's been actively working with our program staff to identify and address disparities. At our CAB meeting last November, staff provided preliminary results of a recently completed HIV patient survey and a detailed review of Stony Brook's 2015 care cascades. And for those of you who are not in New York State, New York requires that, or asks each HIV program to develop a care cascade for their institution. In 2015, the care cascades focused on patient retention and viral load suppression. In 2016, the focus switched to more antiretroviral prescription and viral load suppression. And for our care cascades at Stony Brook, we break down our overall retention and viral load suppression data by clinic, gender, race, ethnicity, age, and mode of transmission, and this allows us to identify disparities between subpopulations. At our March CAB meeting, staff provided final results of our 2016 consumer surveys with results broken down by clinic, language spoken, gender, and age, as well as a detailed review of our 2016 care cascades. Then CAB members and program staff compared the results of the 2015 and 2016 cascades and discussed possible reasons for the disparities identified. Staff discussed interventions that might impact on these disparities, such as targeting our self-management program classes towards specific populations and implementing a one-time incentive program. And while our CAB usually meets quarterly, it was agreed that we would hold a special meeting the following month specifically to develop recommendations for areas of improvement that would then be presented to the leadership of the adult, pediatric, and adolescent HIV clinics at our June CAB meeting. So the following month, CAB members met and made a list of recommendations that covered commonly identified areas for improvement, specific recommendations related to wait times and care in particular clinics, as well as recommendations related to disparities apparent in the cascades. A typed list of the CAB's recommendations was then distributed to all CAB members, and this is going to be used as the guide for discussion between CAB members and senior HIV program leadership at our next meeting, and that's going to be held later this month. So while our Action Week submission focused on how we're working with consumers to identify and address health disparities and improve the quality of care in our program in general, I thought that in keeping with the goals of today's call, I'd also like to talk briefly about the challenges we're facing with measuring the success of one of the interventions we're using to address disparities, and that is our patient self-management program. So we believe it's important to teach self-management because most of the time we spend managing our health conditions takes place outside of the doctor's office. And for most of our clients they're living with multiple chronic conditions, and HIV is sometimes the easiest one for them to manage. Our patient self-management program includes 2 evidence-based interventions. We teach the Chronic Disease Self-Management Program, or CDSMP, which was developed by Stanford University through a collaboration with Northern California Kaiser Permanente. They did a research project that led to the development of that program. And then also mindfulness-based stress reduction, or MBSR, which was developed by Dr. John Cabot-Zinn from the Center for Mindfulness at University of Massachusetts. So both of these programs are supported by about 30 years of research that demonstrate their effectiveness with reducing symptoms associated with various health conditions and treatments and with improving overall quality of life. Studies of CDSMP specifically have found that statistically significant improvements in medication adherence, even though that's not a skill specifically taught by the classes. And MBSR research has shown improvement in CD4 counts for HIV-positive adults. And while the principles that guide mindfulness-based stress reduction and the chronic disease self-management program are different, the goal of each intervention is to enable participants to develop sustainable practices and to become fully engaged in self-management. And so we'd like to teach both classes because different skills and techniques resonate with each person, so we can increase the opportunity for our clients to find practices and strategies that work for them by doing them both together as part of our program. We now have staff who are trained to offer the 6-week chronic disease self-management class in English, in Spanish, as well as the HIV-specific version of the program, and we've also trained several of our peers to lead CDS-MP classes. And for those who've successfully completed the 8-week MBSR program series and would like to continue to build on or reinforce their skills, we now offer a monthly series of classes we call Sustaining Mindfulness. When we initially applied for HRSA funding to develop our patient self-management program, based on all the research that had been done that demonstrated effectiveness, we were fairly confident that we were going to be able to show improvements both in our patient retention rate and our viral load suppression rate. And particularly, we wanted to do this for the 2 populations where we had documented disparities, or 2 of the populations where we had documented disparities, which was HIV-positive women and youth. And we had intended initially to compare rates of retention and viral load suppression before and after participation in our self-management program for 3 different groups. We were going to look at those who had completed both CDS-MP and MBSR, those who had participated in one or both classes but not completed them, and then those who did not participate in either class. So that was our overall plan, but although we targeted clients for enrollment in the classes who were not well retained in care and or were not virally suppressed, we found that most that actually participated so far were retained and had undetectable viral loads prior to their participation, and they've remained so. So you can see where I'm going with this. This presents a problem when you're looking to measure improvement if patients are already stably retained and suppressed. So for example, over the 2 years from January 2015 to December 2016, 24% of participants in these classes showed a decrease in their viral load, 3% had an increase, but 73%, so the whopping majority, remained stably suppressed. And despite the difficulty with demonstrating improvements using our retention and viral suppression data, we really believe that the programs are benefiting our clients. This is supported by staff observations such as decreased frequency of frantic phone calls for assistance from patients who participated in the programs. Also, clients have told us directly that they're using the strategies they learned in the class to better manage their daily lives and the stresses related to their medical conditions. We also think it's really important to offer these classes because many of the women that we work with have histories of trauma, and as Laura mentioned, this is something that's true in her program as well. I'm imagining in almost all HIV programs around the country, extensive research has demonstrated a link between experience of trauma and HIV infection. So some of the key coping strategies that are recommended for those who have experienced trauma are training in things like mindfulness, breathing, yoga, problem solving, positive self-talk, stress management, communication skills, and all these things are the kinds of things that are taught in the MBSR classes and or the chronic disease self-management classes. So over the years, we've found that many of our clients sometimes are stable and other times, often due to life stressors, they struggle with adherence. So even though we're not really seeing patients stay stable as a result of participation or after participating in the classes, it may be possible that had they not taken the classes, that cycle between adherence and non-adherence would have been happening more frequently, or they might not be spending as long the length of time in the stable part of the cycle as they are now, but it's really hard to measure that kind of an improvement. So moving forward, we're trying to think of other ways we can measure the success of our self-management programs beyond retention and viral load suppression, which were the things we initially thought we would see improvements in. So one of the examples is I'm going to start looking at CD4 counts as well as viral loads when I'm looking at pre and post data to see if we can see improvements in CD4 counts for those participants who have been stably virally suppressed both before and after the program. And we're also right now looking for validated screening tools to assess things like ability to perform activities of daily living as a way to measure improvements due to participation in these classes. We've found some that we think look okay, but if anyone on the call today has an instrument that they really like for this purpose, that would be great if you could share it with me. And I don't know if we have time right now. I did want to share, or I could share information about an instrument we are using that's giving us some good data to show impact of our MBSR classes, but it's not related to retention or viral load suppression. So I could talk about that now, or we could wait till later if anyone's interested in hearing about it.
I think you could talk about it now because, and here's why. I love this presentation, especially thinking about spread topic, right? We're wanting to spread learning, and what you're doing is explaining all the things that your initial hypothesis, how you develop the hypothesis, all the stakeholders that were involved in kind of developing and testing the hypothesis, the evidence, and all that is going into the interventions. And it's just the measurement piece that you're kind of like asking about, which is a really important opportunity when we're doing spread activities and we're disseminating our work, but we're also just kind of getting additional information. So, I think both ways, Caitlin, go ahead and share about your tool, the data that you've collected, the tool that you're using so far that's validated that isn't quite the right fit for viral suppression and retention, but is still very important because it's probably indirectly related to retention and viral suppression. And go ahead and ask also and engage folks in a discussion around what other tools or ideas they have around measuring the things that you haven't had a chance to get to yet.
Okay, great. So we currently use a validated psychological instrument to look at perceived stress. It's called the PSS-10. It's a 10-question survey, and it's designed to measure clients' perceived level. We use it to measure clients' perceived level of stress at the beginning of the 8-week MBSR series and then at the end. So clients are asked questions in the survey about how they feel about, how often they felt a certain way about the things in the survey. So there's national normative data available for this instrument that shows mean PSS-10 scores for male and female participants, as well as participants of different races, ethnicities, and age groups. So we've not been able to get data on all of our participants in the classes because some either miss the first class or the last class where we do the surveys, or they fill out the survey in a way that makes it impossible to compare pre- and post-test scores, and I could talk more about that later if anyone has questions about that. But so for those whose data was usable, virtually all of them showed improvement, significant improvement in terms of reduction in perceived level of stress from the pre-survey to the post-survey. And this was even more apparent for those who attended the majority of sessions, and it was striking for those who didn't miss a single class. So it's been, one thing I thought was really interesting, though, was that even though the improvement was significant, the average post-test results for our clients were still showed higher levels of perceived stress than the national norms. And I would argue that this clearly demonstrates the need for these types of programs for our client population. Their pre-test scores were so far above norms that even at post-test they still weren't quite down to national norms. I found it really interesting, though, that this was not, that we had a slightly different thing for staff. When I applied for funding to offer the MBSR classes to our patients, I proposed that we would first do an 8-week series of classes for our staff. And there were several reasons why I did this. One was it was my belief that if staff could see firsthand how much these classes could benefit their clients, they'd do a better job of promoting the program to them. It's hard to get folks to commit to an 8-week series of anything, especially if they're going to have to take a lot of time traveling there. And it would also help staff reinforce content of the classes during their future work with clients if they knew they'd participated. For example, if a problem arose, they could say, I know you learned strategies in the MBSR class that might help with this. What have you tried? Also, I knew that having, like many of you probably, tried to recruit staff who were reflective of the populations we serve, that they would all benefit personally from the training. So for our staff group, when we did the pre-test survey, their scores were slightly above the national norms, which confirmed the classes, but their post-test scores actually did fall within national norms. So the staff, even they're reflective of the target community, but many of them also have had a lot more training and a lot more experience with so if they were, their pre-test scores, they've also received a lot more services probably over the years than many of our clients have had so they weren't under as much stress pre-survey as our clients were, but they were able to get down to national norms by the post-test.
Beautiful. And just one more time, is that the PSF-10?
PSS, 2 S's, Perceived Stress Scale.
PSS-10. Okay,
yeah.
Great.
And we found
Judy,
that
I think the way you were able to get the buy-in not only from the staff but from the leadership, and I was just curious to know, with the success of your program, at what time of day did you hold these classes that you were able to get good enrollment and sustained participation?
So far, we've been holding them during the middle of the day, usually from 11 to 1:30 on a weekday. We have some patients who would prefer to take the classes at night, but we haven't been able to put together a large enough group of them that will actually commit to showing up at night to make it possible to offer them then. With these classes, Actually, the MDSR ones, those usually been 11 to 1. The chronic disease self-management have ended up being more like 1 to 3:30 or something like that, a little bit more later in the afternoon, just depending on the availability of space and participants. But we find that travel is very different and difficult in Suffolk County. We do not have much of a public transportation system, so people tend to get around by cars, but many of our clients try to rely on public transportation or taxis, and travel, like I said, we think of travel in terms of time rather than mileage, so there's really no place that's central enough that everyone can get easily to a location. So whatever location we pick, many people will have to spend a great deal of time traveling. So some people have children that get on a school bus and they have to be back home by the time the children get off the bus. People may live in places where buses only run during certain hours and buses only run on in certain directions. They don't necessarily go everywhere. Trains only run east and west. The train system here is designed to get people into work in New York City and back out. At the end of the day, it's not designed to get around the island itself. So during the middle of the day ends up working out the best for most of our participants because they don't have their own cars and public transportation is so limited and it's difficult to deal with school schedules and things like that. So we are trying to put together one MBSR series in the evening soon, and we're hoping at some point we'll be able to do the same thing with the chronic disease self-management class. We have the capacity to be able to offer, we have enough staff trained to be able to offer these classes at different times. That hasn't been the problem. It's been getting a group of our clients who can commit to come, because since each of these classes is designed to be offered as a group intervention, if only a couple people show up, they won't really get the benefit of the class the way they would if we've got a group of 8 to 10 people there.
Sure, and that's why the face-to-face is so important in this kind of setting. And
yeah, they get so much support from each other.
Yeah.
So, and actually, the experience of trauma, since Laura mentioned that also, the woman who was initially teaching our MBSR classes, we've been trying to get staff trained so we can keep these. We got supplemental funding initially to offer these programs, but we're trying to get our own staff trained so we can keep them part of our program going forward without having to pay anyone else to teach them. But the woman who initially was consulting with us to teach the MBSR classes, she saw quickly from our patients that she couldn't do the class in the traditional order that she normally teaches it, because so many people had trauma experiences, she just couldn't start with particular activities that normally happen in session 1 of an MBSR series. So she had to modify it for our group, specifically because of the trauma experience of the patients.
Wow.
So
actually, I said that in order to be able to explain the next part, which was that one of the benefits of the face-to-face interactions is that people they'll learn from each other that they think that their own experience and the thing they've been through is so unique, and they won't realize how many people have had such a similar experience, and then they can really support each other once they know that. Like, for instance, in one of the MBSR classes, it came out that 2 of the women in the group had actually lost children to violence. And neither one of them normally shares that information, and they both were, it helped them both so much to learn that they were not the only one in that situation and to be able to get the support of each other, especially in the context of a group where everyone was very supportive of them and they had a competent facilitator that was able to lead the discussion. But it was so wonderful that the 2 of them actually got to meet and were able to learn that they had such a shared experience and support each other.
So I shared forward something that Debbie had shared with me, the mindgarden.com link to the perceived stress scale. Hi, Debbie. How are you today?
Great.
Great. Some great presentations we have going on. Especially, I'm wondering if I could pick on your expertise for a moment, just because you've done work around stigma and some of the psychosocial stuff out there. I'm wondering if you have any thoughts or suggestions for Caitlin or folks who are trying to do this type of analysis.
Yes. Yeah, I do. I'm very interested in Caitlin. I'm so excited to hear what you're doing and the baseline data you're collecting. I think one of the struggles that we often have, especially in rural communities, which includes the Caribbean as well as areas, small pockets in rural communities, where it's very hard to invite our clients into group learning activities, even if it's regarding self-healing and self-management, because they may know and have in common many friends, family members, and this is, a fear that is at a very high on the stress scale and often tips the stress scale in my work in using the PSS-10. So we have trouble bringing people in, and I don't know what you may have done to bring this group of people together to ensure confidentiality and safety.
Well, they were for the MBSR class where we administered the survey?
Yes, and just then continuing on with the classes.
Yeah. Well, we have confidentiality and stigma. Those are definitely issues where, even though we're a suburb of New York City, there are definitely rural components to the county, and a lot of people are very fearful that they're going to meet somebody they know in a setting, and even though that person will also be HIV positive, they still are going to be embarrassed to find that they know somebody that might report back to people in their community that they met them there or something like that. So we do have trouble recruiting participants for group interventions. It's something we struggle with, and actually it's one of the reasons why we did toy with the idea of trying to specifically offer these classes for our patients who were not well retained and not suppressed, so we could definitely get usable data, but that doesn't work because you have to have classes to be, and you need to have some people who are actually going to show up regularly, and so the same patients that are struggling with adherence to medical appointments and struggling with taking their meds every day, the same kinds of issues that make those things difficult are also going to make it difficult for them to show up for classes, even if they find the classes beneficial and they enjoy being there. And also those patients may be ones that are more fearful about running into people that they know. So I think what it takes to get people to come to the classes really is the trust that they have in the staff that are referring them. We've had a lot of staff members. I'm so glad that when I initially applied for funding, I said the first class would be offered for staff, because it's been the staff who can share a little bit about their own experiences with the patients and say how much the class benefited them. And if it's staff that you worked with for years and you trust, and they tell you, no, look, I know what you're going through, but look, this is how the class helped me, or this is what I learned in the class. If they can speak about that like that with their patients, and it's been I think the work of individual staff members convincing particular patients to show up that's gotten them to take the classes. We have some people that would come to anything that we, if you post a flyer, they'll show up, but that's few and far between. Most people, we need to do a lot of work personally persuading people to show up. And once they come the first time and they see who's there, then it's easier to get them to come back, but getting them to show up the first time does take work.
Right, and I'm wondering if we collect data on those that don't show up, what we could learn from that. Two things that I'm thinking out loud about would be, one, I'm a telehealth guru, and sometimes having a telehealth helps people who feel isolated but are so fearful of being known to slowly, there could be a two-step process where maybe they complete the assessments and they enter a group setting using a telehealth approach where it's like putting your toe in the water and not just jumping into the cold pond, but maybe testing it out by, can I be known a little bit virtually a little bit, and then test that and see how it feels, and then work with the staff on bridging that, I wonder what it would feel like to show up in person and what that could feel like, assisting people with developing the tools to be able to enter groups and feel safe.
Yeah, I think that we're interested in telehealth too, but I think not for these two interventions. First of all, the Chronic Disease Self-Management Program that Stanford developed, you have to have fidelity to their model, and you can't have, you've got to have, it's an in-person class. They do have something that can be done online. It's a different program, but what we're trained to do is the in-person classes, and we have to follow their model exactly. With the mindfulness-based stress reduction also, there's a lot of the classes involve things like yoga and mindful walking and like different kinds of activities, mindful eating. You have to do it, you really have to do it, I think, in the group setting. I don't think it could be done remotely. But one of the things that we have tried to do remotely has been some treatment adherence work with our patients, where we have tablets. If they don't have a smartphone, we can lend to them. We've tried to do things like have staff call them around the time of day that they're supposed to be taking their meds, and so it's not really directly observed therapy, but try to provide support around medication adherence. And one of the things that we found is that some people and actually we know this from doing home visits as well. Some people, even in their own home, they don't really have a way to participate confidentially. Like they're so afraid of the people in their house learning their status. So we had one young woman who was not doing well with taking her meds, and we were trying to get her to talk with FaceTime at the time of night that she was taking her meds. She would go into her closet in her bedroom where it was dark, but nobody could hear her in the outside part of the house. You know, she would, and so basically you couldn't see anything on the screen anyway because it was all black. She would be sitting in a dark closet with her tablet. And then we've had other people that other people in the house don't know their status, so they wouldn't be able to talk on the phone or on a computer openly, even in their own house. It's safer for them actually to leave their house and come to a group someplace else, because the result of their housemates finding out or their family members finding out their status could be more problematic than running to somebody out at a meeting.
Right, and finding out on our surveys whether or not there is a safe place. Maybe it's not in their home because the fear is that they could be dismissed from their home or kept into their home. I've had clients with mental illness and who are HIV positive who have been forced, once the family found out, and they live in the backyard in a lean-to, essentially. So, you know, the consequences of being found out could be just beyond any of our imaginations.
Oh, yeah.
And so, you know, some of the tools that we can get that out with would be helpful. There's a new intervention, and I just heard about it today by a researcher named Turin, and I need to do a little bit more research on it, but it's about using storytelling as an intervention to address stigma, to enable an individual to share some of their stories in a very safe environment, to talk about what's happened to them, what they've experienced, so that the healthcare providers can then share back, hey, I am so glad that you're sharing this with me, and let me tell you that you are not alone, that I have several patients who have experienced this, or I've never heard of this before. This shouldn't happen to people, and really use that trauma-informed approach to ease someone into that very safe situation where we can coach them and help them develop skills in resiliency and some of the other things that need to happen for them to put their foot or their toe in the water in a group setting.
Mm-hmm.
And I do have a recommendation for you on the side for your ADLs or functional abilities. I'm an old pulmonary rehab nurse and actually have some examples of tools that might be helpful to you.
Okay.
Great. If you could just put those in the chat room, Debbie, that would be really amazing, because then everyone else on the call can benefit too and check them out. And of course, anything that's in the chat room will wind up in the chat transcript, which will be saved and distributed to everyone following the call. So I know that we have one more presenter, but I did see some really super stellar comments by Laura in the chat room. So Laura, I'm wondering if maybe you could just raise quickly what your thought was in terms of the quantitative data and qualitative data. I thought that was really, really cool idea.
Oh, well, I was just thinking about what some other things. It seems like it's a really amazing program, but you're looking for, you know, different ways to show how amazing it is. So I was thinking maybe, like you said, you were looking at the CD4 or I don't know. I mean, I'm not a physician, but other inflammatory markers or something that is more related to the health status of having that additional stress on the body. Maybe you would see something there. I don't know. But also, I think, you know, there's a lot of value in getting the qualitative experience, and I know that takes more time, but I was thinking about the training that NQC did in Washington State where they, I think it was Adam, was talking about different ways to get qualitative experiences of just asking people for different words at various points and doing kind of word clouds around it, but trying to really, or doing, you know, brief before and after interviews with some questions about coping strategies or things like that to really draw out the impact that it's having on the patient's quality of life and their experience. Might be helpful if it's, you know, for evaluation for funders or trying to demonstrate that. And then I was just brainstorming for if the transportation is the major issue of maybe trying to find, you know, if there's certain communities that are more impacted, maybe finding a location to offer the classes that's closer, but then you run into the problem that Debbie was talking about, maybe they're going to be closer to people they know. So I don't know. I was just trying to brainstorm and throw things out.
With the chronic disease self-management classes, we already offer those in different, each time we hold it, we've been holding it pretty much in a different location. So we're trying to move around the county so that we can make it easier for different people in different spots to access the classes. So the one thing, though, with the mindfulness-based stress reduction is we really need a space, a big open room with space to put down yoga mats and to do different kinds of exercises and things. So many people's rooms that have tables in them won't work for us. That's a class that's a little harder to move. We are looking for other sites, but it's got such specific requirements in terms of space that one's a little bit more difficult. But the location we do have for that is fairly central compared to where we could be having it. But that's not been such a huge problem with that class. We would like to be able to offer it in the evening as well, and we could use that same space in the evening too if we could get the full group. If we could get a full group together, that would be available.
I wonder about asking, like, yoga studios who at least often pay voice to, caring about communities and people, but if they, I know that we have some good yoga studios in Tacoma that have community classes or something like that, but just asking them if there's a time they don't use, that they could donate.
Most places here like to charge for use of their space. Even some agencies charge for their space, so we actually have to be careful with the community agencies. But we're looking for places. That is one of the staff members who actually pays to attend yoga classes. Someplace was trying to see if she can get space at the studio that she actually goes to, because they maybe respond better to one of their own paying customers than somebody from the organization. But yeah, we are looking at that kind of stuff. Thanks.
Great. Well, we have about half an hour to go. Lots of great conversation to be had and plenty of super comments in the chat room. But I do want to be mindful of time and move forward. We're going to hear, Judy will introduce Christine in a moment, but I think one of the great things about a webinar like this is that we've just heard from two clinics that are on opposite ends of the country. They're both from the north. But now we're hearing from a state. And, when we think about these concepts and topics in the concept of a network, a Part A or B network, and we know, of course, that there are a few C networks and a couple of D networks. But as a network, we're more meta, right? Because we're not necessarily working with patients one-on-one ourselves or as a team, but instead, we're trying to work with groups of providers that we fund as a team. So that's where it becomes a little bit more meta and kind of is a little bit different. And that's why we're really excited to introduce Christine, who's going to talk a little bit about California. I don't know, Judy, would you mind introducing Christine?
Absolutely, my pleasure. I'd like to introduce Christine Kibbe, who will talk about her work across the state of California. Christine is the Clinical Quality Manager for California's Part B program. She's still relatively new in her role, but has been eager to dig into this work and to make a difference in the lives of people with HIV in her state. As we all know, quality improvement can feel like a cha-cha. It's 2 steps forward and 1 step back. But the most important thing is the framework we use to identify opportunities for improvement and the selection of interventions to bring about that improvement. Christine, welcome, and thank you for your time.
Hello. Thank you, Judy, for that great introduction. And yes, I am new to this role as of June of last year. And to echo Laura Jackson's earlier comments, the end disparity exchange was very timely for our California Ryan-White Part B program. It started at the same time when we were working on revising our clinical quality management plan and also rolling out the California's integrated HIV surveillance, prevention, and care plan, which we call laying the foundation to get into zero. Both these plans emphasize ending disparities, so this was very timely. And as Michael was mentioning, it's a different layout for a Part B, a state Part B program, because we're not working one-on-one with patients. We're working we're funding agencies.
To make an appointment, call the Drexel Neuroscience
Hold on just a moment. Put us on hold. There we go. Sorry about that, Christine.
Oh, no problem. So, for example, we are the state receives Part B funding, but we have other RAN-wide funding going on also in California. Just for example, we have 8 Part A's, we have 41 Part C's, we have 9 Part D's, so a lot going on. So the end+disparity exchange provided a start point for CQM.
I'm sorry, Christine. I just got a little request if you could speak up just a little bit.
Okay, sorry.
No, that's okay.
Maybe increase my volume. Okay, so the end+disparity exchange provided a start point for our CQM program by providing tools such as a disparity calculator, and Michael was gracious enough to provide an unlocked version that enabled us to look at multiple populations and measures at the same time, and he was also available to answer my endless questions. So we looked at mostly at viral load suppression data with the unlock calculator, and we identified that our youth ages 13 to 24 were most affected by health disparities. And please note, again, we only looked at data for clients served under the RAN-wide Part B program. And then we did a little more information on how we use the calculator is we looked at the identified priority populations, that is MSM of color, transgender persons, youth ages 13 to 24, Latina women, and African American women. And then although NQC calculator looks at the Latina women and African women together, we had enough number of clients served in these groups that allowed us to look at them separately. And also, we used our statewide surveillance data that helped us to narrow down our focus to youth ages 18 to 24. Those were the most proportionately affected age group. So here are some of the things that we're doing with this information. We have been informing our stakeholders what our data is showing us at every opportunity we get. For example, our Part A planning councils have been informed of this. We have monthly bulletins that have been highlighting that we're working on this population. And even in our regional group, quality improvement group meetings, we have been informing our stakeholders about this population. And then we have identified subrecipients. We have 42 subrecipients overall, and we have sub-subrecipients. So we have about 82 providers that serve our RAN-wide Part B clients. And just to give you a background, 50 of them are serving youth in this age group, 18 to 24, and 35 of all these providers have at least one youth client or patient that is not virally suppressed. So we have identified providers that have overall performance of greater than 80% viral suppression in the youth they serve to share best practices with those that have less than 80% viral suppression in the group. And we're in the first phase of planning, So subrecipients have done some data exploration and data checks, as well as provided us with perceived barriers to attaining viral suppression in this age group. And this has been very valuable. We've gotten very valuable information through these data checks, and we're still in the process of analyzing this. And as this data check continues, we're also exploring information of a learning collaborative across the state to promote peer learning among our providers and provide current evidence-based quality improvement tools. So, and since this is the first time we're doing it, we anticipate it will take some time to put it all together. And then we have been identifying subject matter experts that can speak to best practices in retaining youth in care and achieving viral suppression, and also identifying effective use of other support tools that can be used to engage youth in care, such as technology. At the Youth Learning Exchange in April, we did learn from presenters how powerful texting can be with youth. So we're exploring such such ideas. We're also highlighting this group as the youth as a priority group for our case management services. And most importantly, we are exploring ways that we can engage our youth consumers so that they can inform our processes. So I wish I could say that we have done this great intervention and present you with our great outcomes, but as you can see, we're still in the planning phase. However, we're very hopeful that we'll be able to work together to support our youth in achieving optimal health outcomes. So I'd like to finish off by just thanking Michael and NQC team for supporting us through this. And to everyone who's listening, if you ever need a cheerleader in quality improvement at least, Michael is a person for you.
Thanks so much, Christine. I really, really like hearing from your perspective as a network that really your interventions that you can do at your level are connecting people who are higher versus lower performing, so that buddy system, but also by creating a learning network or a learning collaborative by which you can have prolonged group learning and exchanges. And I'm wondering, I know that this is something that you said is still preliminary, but I'm wondering if you're going to create a toolbox that people can potentially select interventions from, or if you're going to just kind of leave it open and allow people to select whatever interventions they feel are most appropriate or promising for their own settings.
We hope to provide what best practices are out there, but then leave it open for people to choose what's going to make sense and what will work for their own jurisdictions or locations. We want to appreciate that even though it's a best practice, it does not mean it will necessarily work for that group. So we want to leave it open.
Great. And I got really excited when I heard you say that you wanted to try to find a way to engage your youth consumers to become involved in the process. I think that's one of the things that is just extraordinary about some of the other work that's happening in the field in terms of, consumer-driven process. And I don't know if that's something that you're kind of at the initial stages for, or if you have a group of youth that you already have in mind or that you're already working with, or could you tell us a little bit more about that?
Unfortunately, it's also in the initial stages because we have not had youth or consumers directly informing our quality improvement processes. We do have consumers in our California planning group that give us feedback on some of the things we're working on, but this would be more in targeting mostly the people that we're working with. That would be the youth. So we're still in the initial planning stages also.
Great. Now, the cool thing is that since these calls draw people from all the different settings as well, I see a whole bunch of people that represent states and cities. I don't know if anyone on the line who represents a state or city wants to talk a little bit or provide advice or ask a question of Christine in terms of, comparing what you've been doing or what you've done with what she's just described. No? And if you're on mute, just a reminder that you can press the orange button to the right of your name, or you can press *6.
I can say something. This is Lara.
Hey, yeah.
I don't work for a state now, but I used to work for the state of Louisiana. And just in terms of working with disparities, we were a state that was CAPAS funded a couple of years ago to specifically address disparities in the state of Louisiana, and there was various things that happened, but I always try to share this whenever I can, but I really think an important thing that the state did was for Louisiana, our disparities were really in our African American populations and gay and bisexual men and transgender, mostly transgender women. And we, as a state, we all went through various trainings, Undoing Racism. They created a training about deconstructing like heterosexism and homophobia and transphobia. So multiple day trainings for the entire state staff, and then also some of our funded partners. And it wasn't one of the interventions that we did specifically with the community and our clients, although some community members did participate in the trainings with us. But I really think it helped to kind of imbue all of the HIV workforce across the state with this new focus, and I think a lot of good things came out of it, and it really changed the types of conversations we were having, and so I think that out of that came a lot of great stuff about, you know, hiring practices and who was moving up in leadership, and you know, I think we don't, like I said, it wasn't like a direct patient intervention, but it was really effective in starting us moving in the right direction with disparities.
Thanks, Lara. That's very helpful. And if you don't mind, maybe I can reach out to you later for more information about that.
I'll redirect you to Louisiana.
Okay. Thank you.
Great. Any other questions or comments for Christine before we move on to our discussion?
This is Judy. I just had a question a little bit about the new learning network system, and what do you envision that's going to look like, a little bit of the logistics of how you're going to cover such a broad area and keep the message consistent, or the opportunities consistent.
Hi, Judy. Thanks for that, but that's a big question. We're determined to do it, but so we're working on the planning part to make it meaningful. So I can't really, we don't have a final product of what we think it's going to look like, but we are planning on it.
Thank you.
So I do want to point out that each of these presenters today, each of these great folks submitted something to NQC for the Action Week that was part of the end+disparities Learning Exchange. For about a month, we had an open submission process where, you know, we invited people to let us know what they had been doing. Some folks submitted videos, some folks submitted tools, some folks submitted narratives, and we received 14 in total. We're going to be putting together this all of this information into a dissemination package that we're going to share with our federal partners and then share with all of you through available resources at the NQC and also the Target Center and many other areas, just because I really believe that this learning that we've heard just, you know, 20% of today is really important in helping us to get additional ideas for what we might try at our own sites, and also just to give us that shot in the arm sometimes that, you know, the things that we struggle with are things that a lot of folks struggle with when it comes to, you know, being very passionate about, you know, helping people with HIV live long, full lives, that we're passionate about health equity. And sometimes it's frustrating to feel like we're kind of treading water or not able to move forward. And I just think that it's really great to see stories and hear testimony from other people in terms of what they have been able to accomplish and how they've overcome challenges. As we've heard, lots of successes shared in these three presentations, and also plenty of challenges as well. I just wanted to recognize, I see that she's no longer with us on the line, but the winner of our drawing was Sandra Candelaria from Howard Brown. So thank you to all 14 folks that made submissions for Action Week, and congratulations to Sandra for winning our prize drawing. Judy, I don't know if there's anything that you want to kick off the conversation with.
I was just wondering if there are any submissions that you'd like to highlight that you think were, you know, besides the ones that we've got today, but anything else that you wanted to mention?
Yeah, you know what? Actually, I'm going to turn that back to the crowd here. I see that a couple other folks who made submissions or made comments to us regarding Action Week are on the line. And would anyone on the line like to share what they submitted? Well, I think one of the things that I'd like to highlight is the degree to which, you know, from both, I'll address both the provider and then the network side. On the provider side, I really liked the way that a lot of sites use the calculator to identify and to start a conversation either with staff or with consumers. It was interesting to me to see that a lot of folks actually did take the calculator right to the consumers and said, let's talk about this. Of course, that meant that they had to have a sense that their consumers were ready to talk about data at that level and to talk about statistics and what these various values meant. But it was really encouraging me to see, for me to see that there were so many agencies that had consumers that they felt are at that level and that they you know, had that conversation with their folks about that. A lot of the interventions then that came from this had to do with training. Training the way that we work with our call centers to to include specific language when we make calls, or the addition of in-person calls on top of the robocalls that most of us have as our standard practice today in an electronic health record environment. I also thought that it was interesting that that the way that care is delivered in terms of timing and in sequencing was a big change that people did. So the order in which phlebotomy and vitals and the physician, you know, meet with patients, a lot of that were things that were examined from the direct care side. From the network side, we only had a couple of network submissions, but a lot of those actually emphasized very similar things to what we heard from Christine, that folks either ran the calculator only at the central level and then engaged all of the subrecipients in a conversation, kind of like the way that the direct care sites ran the calculator and then spoke with consumers. But then there were also a number of folks that put the calculator in the field and said, do what you like around this and run the data and then tell me what you found. And then the creation of small learning networks and learning groups around what the data said, I think was a really important thing. So, you know, we kind of saw that going in two different directions for the networks as well, that some of the networks manage this more strongly centrally, and others let the subrecipients determine for themselves what they wanted to focus on, and then after the fact went and kind of connected them together based on common interests and goals. So I know that we only have 8 minutes left, and there were quite a few questions left in the chat room on some of the presentations. I don't know if anyone wants to unmute their line and ask a question out loud or engage the presenters that way.
This is Dolores.
Hi.
Hi. I really like the presentation that came out of New York that really focused on using the CAB and consumer involvement. And I think whenever consumers come together, there are some other intersecting topics that arise out of the discussion, because oftentimes when you are dealing with retention and viral suppression, some of the things that impact that are not necessarily just about HIV. It might be about some of the other life issues that people are dealing with. So I just wondered if in that encounter and in that discussion around stress, if there were any intersecting topics that emerged that were probably signal that they had to be dealt with first, or signal that these topics need to be addressed in order to kind of have the success you wanted. So I just wondered about that.
This is Caitlin. I think that although the staff in general had recognized that, you know, based on data and conversations with individual patients and things, that many of our patients had experienced trauma, I think that through the self-management classes that we've been offering, that's really come out strongly, that trauma is huge. And then the more that staff have become aware of this issue and the more we've been listening to webinars and reading books and things like that, I think the more that that's going to become a bigger focus of our program. One of the things that I've done recently is I've identified some books and some audio books, and I've given staff resources to be able to download them from our library system on their phone to listen to while they're driving in their cars, which we spend a lot of time doing here. I just feel like there's so much research that shows that stress has such a, first of all, many people who have HIV, particularly many women and many MSM, have been impacted by trauma. Trauma that's not addressed is going to impact their ability to be adherent to treatment. It's going to be, it affects the functioning of the prefrontal cortex. It's like so many different impacts. I feel like one of the things that's come out has been that we really need to do more to work with our patients who've been impacted by trauma.
Thank you.
So we have 5 minutes left. Additional questions or any aha moments that anyone wants to share? This is the last official, hour-and-a-half webinar of this initiative, and so, if you have any aha moments that, kind of carry over from the beginning to now, we'd be really interested in hearing those.
I think one thing for me was being like more of a public health program person. I didn't realize then when meeting with our clinical staff and doing this, and so I would, we identified disparities, and they were like, oh, that's really interesting. But then when there was a couple groups that I said I did the chart reviews, I actually brought the names of the people to the clinical staff, and when I said the names, there was like a click of like, oh, like I think when you meet with people one-on-one all the time, you see, you're like, you recognize that, they know that there's the mental health and the housing and everything like that, but there was like an aha moment for them when then it became like, oh, these people all have the same thing in their youth, and these people all have the same thing in their, I think it's hard. You can get feelings, but you don't see patterns in the same way when you're in the midst of it. So I think that was an interesting thing that I hadn't thought of.
Cool observation. Thank you.
This is Caitlin. One of the observations that we've made recently that's been reassuring to us, so hopefully it will be to some others that are struggling with things like viral load suppression among youth, particularly for our perinatally infected youth, we were finding that their suppression rates were the lowest of any of the populations in our care. And one of the things that's been interesting that we've noticed is that as these youth are aging into adulthood, it seems like somewhere around the age of 25 or so, they start taking their meds again. So the rates all of a sudden are improving. Our viral load suppression rates clinic-wide are improving because our youth are starting to take their medications. And for some of them, they had health scares. And for other ones, I think that it's just the maturing into adulthood and having full function of their, the brain's fully mature and everything like that. And so for those of you who are struggling with adherence, particularly among your youth and your perinatally infected youth, if you can keep them in care, even if they're not taking their meds, if you can keep in contact with them and provide support services, and they can live into their middle 20s or so, you may find that they're starting to, that they'll be adherent again to their medications and become suppressed.
Thank you very much. And I see in the chat room, Kimberly noted that they're specifically addressing trauma and violence in the development of their quality improvement plan, which I think is really novel and kind of, it's exactly where a lot of folks are going to be heading, I think, because there's been a lot more attention drawn to that and focus, and quite a few of the conversations today actually focused on that. So thanks for sharing that as well.
Michael, this is Judy. I just want to take this opportunity, since we're running close on time, to say what a wonderful series this has been with this learning exchange, and I think today's webinar was one of the best that I've participated in and listened to, and I think it's great that, people can have aha moments months from now and they're able to go back and listen when the timing is right for their agencies or programs to learn from these webinars and to implement interventions when the time is appropriate. So I just, for one, want to thank you for leading this wonderful initiative.
Oh, thanks, Judy, and thanks to you and the other coaches who have been involved in planning and implementing this initiative. We wouldn't have been able to do this without you, and also for the wonderful support of Emily Chen and other folks here at the NQC office. And of course, a big warm thank you to all of you in the field who have been participating in this initiative and listening along. And for those of you, as Judy noted, who might be downloading this a year from now, thank you very much for focusing on disparities in HIV care and for your passion around health equity. We really make a big difference together. Now, I just wanted to point out that we have a couple more items left in the calendar, 2 in fact. Next Thursday at 1 p.m. we have the Partners in Care iteration of this webinar, where we're going to be looking at this from the consumer perspective and sharing what consumers have done and what consumers can do around this work to keep it moving forward, to make sure that none of it's lost and that consumer communities around the United States can all benefit from learning that happened in this exchange. Excuse me. And then the following day, next Friday, we have our final office hours, which is going to feature a article that was penned by Terry Fox in conjunction with Adam Thompson, myself, and Donna Van Alst, which looks at the many roles of social workers in shaping quality of care in transdisciplinary teams as we get to zero. And so the concepts, several of them actually, that we spoke to today in terms of having a central social worker or case manager role to help in interfacing between the patient and the care system, which has, you know, it's a village, as we all know, actually helps to drive faster, better improvement, as shown in the In Care campaign. So we're really excited to engage you next week in that conversation. And again, just thank you very much for all of your time and your effort and your attention in this initiative. My boss, Clemens Steinbach, is not around today, but I know that he would very much echo the sentiment, and thank you from the bottom of his heart for all of your participation over the last 9 months. So with that, I will bid you farewell. Be on the lookout for an email coming later today or first thing tomorrow that include the recording, the slides, and the chat transcript, along with, of course, our evaluation, which will help us to plan future activities like this one. Thanks again for all you do, and have a wonderful day, and we'll chat with you soon.
Bye.
Thanks, Mike.
Bye, everyone.